great pleasure. It's a great pleasure for me being here in this second symposium of TUGS Women. And we're going to talk about some controversial topics, but very, very interesting about women in medicine and in surgery. And today we're going to start by Dr. Sonia Chiappetta. She's the director of her own bariatric program in the Bariatric and Metabolic Surgical Unit of Ospedale Evangelico Betania in Naples since March 2018. It's a center of excellence in February 2020. And she's involved in a scientific life, and she was a member of the 3rd European Obesity Academy from 2015 until 2017, and she's also a member of the 3rd European Obesity Academy, the European Academy for the Study of Obesity, and she is an excellent reviewer in several journals as Obesity Surgery, International Journal of Cancer Oncology, BMC Surgery, Drugs of Today, and the Journal of Investigational Biochemistry. So please, Sonia, when you want, you can start your presentation, your talking.
Thank you, Elena. Thank you, Aperna, for invitation. I'm honored to be part of this second TUGS Symposium. Thank you, Elena, for organization. And yeah, you give me a quite interesting title. So preparing the presentation, I recognized that the last 15 years I spent for surgery for my career. It was quite impressive, I have to say. Mm-hmm. But now I want to share the screen, but it isn't possible. Because it says it's deactivated.
Just 1 minute, Alina, I will make you the co-host. Sorry, Sonia.
Yeah, no problem.
You should be able to share now.
Okay, perfect. Okay.
Perfect.
So I want to start with my disclosures. At the end, I'm a medical doctor, I'm a surgeon, I'm a scientist, and I'm a mom and a wife. And I have to say, this is quite all of my life. I would love to play the piano. I would love to speak French, but these are things maybe I have, or I can do, I can learn in 40 years, but poorly, having this job, having this kind of life, you have only small time for family and friends, and you need hobbies, but poorly, you have really less time for other things. And I want to start to talk a little bit of my life, because at the end, getting a leading position, in my opinion, needs some basics. And I have studied in Frankfurt in Germany from 2003 until 2009. And now remembering my studies at the end, the PhD thesis was an important beginning for all my work, because it was an experimental thesis. I first operated in my life. I operated on rats, and I did it in the Radiological Institute, a really famous radiological institute. And at the end, I presented my results also in Berlin at the Congress. So as a student, this was the basic of my scientific life. And at the end, After studying, I wanted to become a dermatologist or a surgeon, a plastic surgeon, because I thought about, a good lifestyle, running the world in nice clothes with a nice car. But at the end, I preferred blood, vomiting, ischemia and pus. And when you ask why, I can't answer you. But the problem is, or the nice thing is, when you have a passion, there's no plan B for passion. And when I think about my life, I have two passions. When I was young, it was the ballet, the classic dance. And since 15 years, it's surgery. And when you allow your passion to become your purpose, it will one day become your profession. And I think this is the greatest gift to have, to do something you love, to do something where you feel the passion. And in my opinion, when you have a job which you like, and which you like more than all the other things, it's also easy to work a lot, to work hard, because you like it. And timing, at the end, I spent the best days of my life in the OR, I have to say. I did Erasmus in Milan in Italy, because I loved Italy. My father is Italian. I was born in Germany, but I also loved Italy, the culture, the mentality. So in the last year of my studies, I went to Italy, and I performed my surgical program in Italy. And where I met my further husband, you see him on the photo. I had only 23 years, and I was a student. He was a surgical assistant. And at the end we shared our passion. And I spent so many time in the OR. I loved it. And that was the beginning. And as I said before, I told him I want to go back to Germany, because I want to become a plastic surgeon. But at the end, I knew general surgery, and I started a 2-week of plastic surgery fellowship in Germany. But it was so annoying, when you get to know something that you like more. So at the end, I started with general surgery. And I started with Professor Rudolf Weiner, a famous bariatric surgeon, and in Frankfurt, in my city. So this was the beginning in 2010, and we were a department of general surgery. And this I didn't recognize at the beginning, but very soon, we had a really, really famous chief. And this is my first important skill to tell you: choose a famous mentor if you can to. And the second thing is work with great women. And I am so happy that I have worked with Christine Stier. I think everybody knows her. She is a famous bariatric endoscopist. She is part of the IFSO committee. I worked with Sofia Teodoridou. She was the left hand, the surgical left hand of Rudolf Weiner for so many years. And I worked with Sylvia Weiner, and she's the daughter of Rudolf Weiner. We have quite the same age. And I think these three women were important for me. to become also a surgeon, a female surgeon, because when you are surrounded only by male surgeons, maybe you can't have an idol. And I have to say, all these 3 women have children. So it's important for a female surgeon to see that you can have a career, but you can also have a life as a woman. That means you can become mother. So this is important, and you see in this photo all over the world, we have these women who are getting always more popular. And yeah, you have to organize congresses. The Frankfurter meeting is the child of the Weiner family. And I started in the beginning, just in 2011. We had always live surgeries. I had to speak with the surgeons. We had to organize it. We had to write mails. And I did it from the beginning. At the end, this is politics, but it helps you to get to know the important bariatric society in my case. And then after 3 years, I went back to Italy, to the San Raffaele hospital, because my husband got an important requirement in surgery. So I also went back there, and there I stayed in the pancreatic unit, in the transplant unit, and I have to say, there I learned a lot of surgical skills. And so stay in the OR. If you want to become a female surgeon, you have always to stay in the OR. You have to learn the basics. You have to learn to operate. You have to get the anatomy. You have to be present day and night. And so this, quite 1.5 to 2 years at San Raffaele Hospital, my husband and me, we lived there. We lived in the OR. For me, it was really important because bariatric surgery is so specialized. It's laparoscopically, and there I learned, the open surgery, and this is really important. And you have to be curious. You have to do science. And I have to say, I was there in the pancreatic unit, and they talked about the problems of diabetes after pancreatic resection. And I remembered our bypass patients, and I said, maybe there are also patients who have a amelioration of diabetes after Whipple procedure, because we exclude the duodenum. So this curiosity at the end was the beginning of my scientific work, and we studied it. I presented it on the Congress. And when I then came back to Germany, I went back to Rudolf Weiner after 2 years because the contract of my husband finished. I was so happy to do science, and I said, we have to go on. We have so many patients, and we have to study different things. And this was the time then in 2015 where Rudolf Weiner opened the first department of obesity and metabolic surgeries. We had 42 beds. We were really a great group. We had our operating room, our own endoscopy, our outpatient department, the intensive care unit. We had 1 chief, 4 autonomous surgeons, and 6 residency, and we performed quite about 800, 900, 1,000 surgeries a year, only bariatric surgeries. And this was so quite important for me, because at the end, when you get super specialized in one thing, obviously you are better than a person who does it once a week or twice a week. And this is really important. You have to have the basics in general surgery, but think about the specialization. Up to date, it is not possible to do everything at the highest level. And I have to say, in my career, in the last year of residency, we had the Department of General Surgery in this hospital where I worked for 6 months, because they did upper GI, esophageal cancer surgery, and the chief of the department, Professor Lorenz, he was also an important German professor. He asked me to stay with him. And he said me, yeah, it's not a good idea. You are a woman, and to get specialized so young, you have to do everything. When you're only doing bariatric surgery, what is the future? And I remember this day I called immediately Professor Weiner, and I said, what should I do? And he said, oh, go there. And I was so angry. I said, how can you tell me go there? I did bariatric surgery, and this is my passion, and I don't want to do everything. And so we decided together that I stayed in his department. And yeah, retrospectively, I think it was a really important decision, because yeah, it was my scientific part, and also surgically, I was just autonomous at the end of residency. And so yeah, in your life you have to decide, yeah, to go further. And yeah, you have to work hard. You see our faces. We always worked hard. And the most important thing, you have to study and care for your patients. You have to know everything about your patients. And this is one thing I learned at San Raffaele Hospital. When you work and you have to present the patient as a residency, yeah, quite at front about of 20 colleagues, and yeah, you have to know everything. You have to know the blood values, maybe the date of the last chemotherapy, radiotherapy in our bariatric patients. You have to know the eating behaviors. You have to know them. And this, in my opinion, is important to be a good surgeon. Yeah, and then I went specialist in 2016. Yeah, this was a point of no return. I told you the story that I decided to stay in bariatric surgery. So this was my goal. This was my plan. I stayed focused, and yeah, I worked hard and succeeded. And sorry. And yeah, for me, it was important that I have changed city and country, and that I knew also different mentalities, different chiefs, different yeah, ways to work. It's important to have your own structure. Obviously, you have to study and you have to write, and this you have to do at the beginning, when you have still time, when you're still in residency, because the older you get, also with maybe family, the less time you have. So study and write from the beginning on. When you get older and when you are yeah, a little bit autonomous, organize workshops, obviously maybe at the national level at the beginning, and when you can also at the international level. be politically active. I was the secretary of the German Association for the Study of Obesity for 3 years, and it was important. I knew the whole German Bariatric Society, and I interacted with them. So when you are interested, do something politically also, because there you can change political things. And I think international, up to date, we have the advantage to be connected with the webinar, so you can think international from home, but this is important. You have to know colleagues from all over the world. And this is the summary of my way to get a seat on the table as a female surgeon. But I have to say, it's not only this, because when I went to Italy and when I got here in Naples, the bariatric program, I learned so much more. Because at the end, as a leading surgeon, you have to learn how to be strong alone. Because at one time you arrive and you are alone. Maybe you can discuss with old colleagues, you can discuss with friends, you can discuss with your husband, maybe you have a background of your family, but when you have a chief position, you have to be strong alone. You have to manage things. You have to decide things, and this is important. You have to know it. You have to be prepared mentally, and you don't have to be afraid that men maybe are better than female surgeons. I have to say, be a woman. If it's possible, obviously, get a child. I have only one child. I would love to have maybe 3, 4, 5 children. It's not possible for me in this job. But take the positive part of a woman. We are sensitive, we are warm, we have apprehension. And this is important also for our contact with the patients. So don't forget to be a woman. Female surgeons have a positive thing. All my patients love me because I appreciate their problems. And this is an advantage, don't forget. And you have to be organized. You can't be a female surgeon when you are not organized at home and at work. I have to delegate. I have a babysitter. I have a housewife. She's living with us. We have the concierge. He's doing the things my husband doesn't want to do. So you have to be organized. You have to delegate. You have to reflect. You should examine yourself daily. If you found faults, you should correct them. When you found none, you should try even harder. You have to be resilient. It's important. Surgery is a hard job. You have complications. Maybe you have colleagues who don't agree with a certain step you're doing. You have to be resilient all the time in the whole career. And in my opinion, the higher you get, the more resilient you have to be. You have to have good friends because there are moments you need them, but this is normal life. Yeah, friends are important, are so important. And you have to be mentally strong. You have to move on. You have to embrace change, and you have to welcome challenges. This is important. You have to like them. If you are afraid about challenges, it's difficult. You do not have to fear. Don't be afraid of mortality. Don't be afraid of complications. Poorly, you have to work hard. You have to decide maybe right in the so in certain circumstances, but do not fear, because if you fear, work is getting harder. And be humble, you can ask for help. Also, if you have a difficult surgery, call someone before, call someone during if it's possible. Ask for help. You don't have to be the best one. When you have a chief position, you have to create a good team and you have to share. This is really important. You can't work alone, and you can't do the best alone. You have to be surrounded by a good team. And finally, you have to love your patients, because if you are not human and if you not love your patients, then work gets difficult, because maybe you spend more time with the patients than with family or friends at home. So thank you for your time. I hope I gave you some answers, and challenge yourself every day. Thank you.
Thank you so much, Sonia. It was an incredible talking, and mainly for your messages, you know, for women surgeons and all the women that want to develop a great career in medicine and surgery. So thank you so much for being with us. And I have a question to you. I want to ask you if you developed part of your career in Italy. So Italy, as Spain, we have some, you know, the fame of Machin's countries. So did you find any difference between, for example, your experience in Italy from Germany, or you feel the same as a, you know, of women in surgery between both countries?
So I have to say, in Italy, it is much harder for a woman. And here in South Italy, I do not know a woman at my age who is autonomous, because female surgeons, surgeons get or start to operate after maybe 40 years. And this in Germany is different, because you have to get autonomous because the chief only operates the private patients. And when you get specialized, you are autonomous, you have to be on call 10 days a month. And the German system is different. In Italy, you have much more surgeons, and the hierarchy is different. At the end, I was fortunate that I was surrounded by women, by female surgeons. But also, when I look at Germany, there aren't so much female surgeons. So at the end, I think in every country, when you have a goal, you can achieve it. So I'm here doing my job as I was doing it in Germany. There's no difference.
Okay, thank you. So I think that we can go with the Dr. Vivian Lim. Okay, Dr. Vivian Lim. Okay, perfect. I'm going to advocate Dr. Oh, so sorry. She is currently the president of the Asian Federation of Endocrine Societies and sits in the executive committee of the International Society of Endocrinology. She held the post of the president of the Endocrine Metabolic Society of Singapore from 2016 to 2018, and she's currently the immediate past president of the EMSS. So please, Dr. Vivian Lim, when you want, you can share your screen and start your presentation.
Thank you very much, Alina, for that wonderful introduction. Can you see my screen and can you hear me?
Yeah.
Very good. Thank you. Greetings from Singapore. It's actually midnight now.
Yeah.
12:30 a.m. and I'm happy to be here with you. Now, I thank you to the organizers for asking me to give this talk. And I have to say, I've never given a talk like this before. I was a little bit puzzled as well. And I asked Alina, I said, I don't think there are studies on this particular topic. Is it going to be a subjective talk? And she says, yeah, that's exactly what we want. So I'll try, I'm not used to that, but I'll try to make it a little bit more objective as well, and also to give my subjective opinion as to what it takes for a woman to make it to the top positions in medical or surgical societies. And I'm going to use medical society to mean both medical and surgical. So let's see. So these, I have basically no financial disclosures to make. Let me put it to my pointer first, laser pointer, there we go. Now this, I looked at the web as with all talks, and I saw this in Singapore. I come from Singapore, and in China News Asia, there was this article in October 2020, and he says gender equality in Singapore remains elusive amid entrenched attitudes about women's roles. Now in Singapore, we are mainly a dominantly Asian society, 70% Chinese, and there's a lot of patriarchal roles out there, thinking that women are a lot of times all the housework, the stuff that the woman has to do at home together with the career. So you can see this picture tells 1,000 words, and you look at the woman and the things that she has to juggle. And what tickled me pink and was quite sad as well was the opening sentence of the article, which says the accounts manager Joanna likens her husband to a useless piece of large display furniture at home, alluding to the fact that actually he just came home and he doesn't do any housework, but she came home after 10 hours work shift and she still had to do everything in the house. Now, I tried to take a look then, trying to be objective, and in the talks that I give, we are very used in endocrine to giving talks with PubMed and looking at the newest data. So I took a look at, do I have data with regards to a gender disparity in terms of the upper echelon of medicine? So we've got this from US and discussing about the women from medical school to surgical training, because this is a surgical group here, and academic leadership from 1994 to 2015. And the interesting thing is the proportion of graduating women medical students have increased on an average of 0.5% per year from 1994 to 2014. The women surgical trainees have more than doubled and represents about 40% of all general surgical trainees in 2014. Unfortunately, the women full professors increased an average of 0.3% through the years, but still make up less than 10% of all full professors. So they concluded then for there to be gender parity, this will only achieve it in 2136. Now then I say, what about in other parts of the world? So we do see this in French hospitals at the same time. And it says that women represented 52%, not bad, half of them of the hospital practitioners, 48.6% of the associate professors, but again, falling short and going to 22% of the full professors. So at the upper echelon, the leadership roles, I'm taking it to mean the upper echelon, the upper leadership roles. Again, we're seeing this gender disparity. Of course, this is an observational study. We're not going to get randomized controlled trial, lots of subjective stuff, lots of confounding factors. We don't really know exactly Why is it that we are seeing this gender disparity, but we do know that there's this gender disparity? What about gender bias in terms of opinions of to profession in professionals and surgeons? And the key point that this study wanted to do in 2019 was the question of, do surgeons and healthcare professionals hold implicit or explicit bias regarding gender and career roles? So the data suggests that the healthcare professionals and surgeons hold implicit and explicit bias associating men with careers and surgery and women with family and family medicine. Now, we know that now there's a gender disparity. We don't know the reasons why. We know that there are subtle biases in terms of even sometimes evaluation of an evaluation for promotion, for remuneration for females. Now, how are we going to correct this? Oh, that's a million-dollar question. So what I shall be talking about, first of all, as in any study, you want to know your assumptions, you want to know the baseline characteristics. In this case, me, since it's going to be more or less subjective, want to know my baseline characteristics, and then from then, the traits that would help with getting that leadership position with regards to these baseline characteristics, taking that into account. So my baseline characteristics. So basically, where am I from and what is my background? So if you look at my background, this is all my background. I'm not going to read it out. I have been a volunteer with Doctors Without Borders. I took some time off for this. These are my leadership roles. That's because particularly with regards to that, because I was asked and tasked to discuss what it takes to get that leadership position in a medical society. Now, where am I from? Well, this is a view of Asia. This is a map of Asia. So let's go through it quickly. China, Korea, Japan, Taiwan. This is East Asia. If you look here, South Asia, which includes India, Bangladesh, Nepal, and this is Southeast Asia, where I hail from, this entire region. So the president of the ASEAN Society of Endocrine, ASEAN, it's the Association of Southeast Asian Nations. So here we go, Southeast Asia. And I'm going to challenge you to find Singapore. I'm going to make it easy for you. That's Singapore. So Singapore, the name is actually larger than the accurate geographical representation of a little dot at the end of this peninsula here. So we are actually 730 square kilometers. To put that into perspective, Italy is 400 times the size of Singapore. We first got independence in 1965. When we separated from Malaysia, our then Prime Minister went on national TV and he cried because he wasn't certain that we could make it. This was 1965. We were a low-income country. We've got racial riots. We had, epidemics. Anything you can think of in the low-income country, you're going to see it there. Malnutrition. This is Singapore now, 2021. World Bank tells us that we are a high-income country. Now, in 1965, we had no natural resources. Remember, 1/400 the time of Italy's space. We had no natural resources. We had 1.8 million people. The then Prime Minister he was very into meritocracy. You're not going to have you're not going to survive if half the population decides that he has to stay at home and not work and not get educated. It's not possible. And he married the only one person who was cleverer than him in his class, and that was his wife. And he keeps us telling that. Okay, so that is the background of where I'm from. I'm a meritocratic society. May the best person win for the job. I'm also an Asian country in which you have lots of patriarchal attitudes at the same time. And my Asian country was 70% Chinese, 20% Malays, and about 10% are Indians. And we are sort of mainly an immigrant nation from the very beginning. So the assumption that I'm going, knowing my background now, knowing where I'm from, and the assumption that I'm going to have, that's in any limitations of studies, the assumption is that you are in a society where females have equal rights and privileges as males and are allowed to achieve top positions, like where I'm from. It's very common to have female bosses, females in leadership positions there. So that's where I'm from, and that's where I'm starting from. So what I'm going to talk next then are traits that would help with getting that leadership position. As with anyone who wants to know anything on the subject, especially our patients, they go into this compendium of the greatest resources of information, Dr. Google. So when I went to Dr. Google, I put in top 10 traits of a successful person. And this is what came out. And I thought, actually, it was quite accurate. I think it's quite accurate. So it's got drive, self-reliance, willpower, patience, integrity, passion, connection, optimism, confidence, and communication. Now, needless to say, if you want that top position, of course, you've got to have credibility, and of course, you have to be competent in your field. That's needless to say. But these are the traits then of, in addition to all those things, that will get you the job. What I thought then, what about PubMed? Does it tell me anything? Well, and interestingly, we have a systematic review of medical leadership in hospital settings. Now, this was talking more about clinicians in medical leadership management positions, but I think it's the closest we can get to talking about top leadership positions in societies. And the features that they find, which would give them that a good leadership quality, would be credibility, skills, knowledge, attitude, and experience in management. I expand a little bit more of this attitude. So the traits that the medical leader should possess. And the most cited traits were motivation, exertiveness, cooperativeness, being a team player, patient-centered, integrity, mission-driven, result-driven. And then it was followed by diplomatic, personable, honest and open, visible, quality-driven, innovative, self-confident, empathetic, forward-thinking, and intellect. So if you look at the traits, not too different from that of what Google came out. So, well, Google has done its job as well. So what about me? What I think then, looking at this, I totally agree with the traits that both that systematic review as well as Google say that a successful person, that a medical leader should possess. But what do I think? I want to highlight some traits which I feel are very important to me, that if I'm going to choose a leader, this is what I'm going to choose. So you have to decide, I feel, and how much time you're willing to put aside. And you have to be realistic and not overstretch. And once you have decided, it has to be full steam ahead. Now, what do I mean about this? Well, unfortunately, this pie chart doesn't give me more than 7 slices of the pie, but it's obviously going to be more than 7 slices. As a woman, and as anyone, you have competing things that you need to do. Things that are important in your life that you have spent time with your spouse, with children, homework, me time, clinical work, teaching, talks, research, society 1, society 2, society 3, and lots and lots and lots of things. Basically, you have so many things that are trying to pull you and that you don't know where to go. And you have to be very clear that if you want that position of the leadership position in that particular society, you have to be clear for yourself and to be answer the question of how much time can you set aside, and you have to be realistic about it. Because let's face it, if you yourself are in conflict over how much time you can devote to that society, the society doesn't owe you anything. Nothing here in the world, nothing is fair in this world. But if someone else, and it doesn't matter what gender that person is, can spend 10% of the time for that society, and you are not certain, and you can only spend 1 or 2%, and you want that leadership position, it's going to be difficult to compete with that person who's able to devote 10% of the time. And that's why I meant, that's where I'm coming from, that if you want something, you have to sacrifice. You have to decide, is it worth it? Do you really want it? How much time can you put aside? And you have to be realistic. And once you have decided, that's where your commitment, the drive, the exertiveness comes in, and it's full steam ahead, and people can tell how committed you are and how much you want it. And you know, and that's already half the battle won. So that to me is really important, that drive, that commitment. it helps to be one of the group. I see another thing which is important as well. Now, a friend told me once, there was this interview of a guy for a high position, and guess where the interview took place? It was a very long interview. It was from 3 p.m. in the afternoon to 2 a.m. It was in a bar, and all they did was shoot the breeze, talk, drink beer, and then he was given the job. And it was a top job, and he was still with the company for 10 years. So that struck me. You have to be this visibility, this part of the group thing. If you can't merge with the group, if you're an outlier, if you're not joining, if you're not visible, you're not seen, it's a little bit difficult then if people are selecting for the leadership position to want to give you the particular job. So it helps to be part of the group. And that's why they say that, you know, the person who's extroverted, who's out there, and the greatest social lubricant actually is sitting and facing each other. And Zoom has taken some part of it away, as nothing beats being there, a 5 or 10 minutes, you know, face-to-face discussion with someone over your favorite beverage, you know, and that really helps. And I think that's important, to be part of the group, to be part of them. And that's one of the, you know, things that will get you that leadership position. And well, the previous speaker alluded to this, and I totally agree. You have to love being a woman and what to do. Basically, it's passion. I can be speaking to a male audience, and I could say love yourself and what to do. It's the same thing. So love being a woman and what to do. You could be a mother. You could be in a top leadership position, whether it's in medicine or otherwise. You could be doing the best things that you like with your friends. Or you could be Christina Young, because I brought her up because she's a cardiothoracic fellow. And, you know, interestingly, my patient told me about 2 days ago, because embarrassingly, I actually didn't know who she was. I made it a point not to look at Grey's Anatomy or any programs in my language or English or otherwise, which is based on medicine, because I'm living it already. Why would I want to see a program based on medicine? So a patient tells me, hey, you know, reminds me of Christina Young. So I looked at Christina Young and I like her. Well, 1 to 2 minutes. She's a go-getter. She's assertive. You know, she won't take no for an answer. Well, she is what I feel a successful woman would be like. Could imagine her in a top leadership position. So I think if you love being yourself and what to do, and it really shows, and that's where that trait comes in again, that self-confidence that's there to show to the world, and people would know it, people will feel it. And I always say, you know, to my friends, I say, you know, what's there not to love about being a woman? And if you think about it, I could wake up one day on the left side of the bed and decide I'm going to go to work with mascara on, you know, thick makeup and a thick pink luscious lipstick with a tight short skirt. Not too short, please, because this is still medicine. And I could do that. And then the next day I could wake up on the right side of bed and decide, look, I'm going to forget about that makeup. I'm going to go in power pants and suit. And I could do that too. Now, guys, I'm sure you can't do that, not in that tight skirt. And please don't do it in Singapore, because I don't think your superiors will be very happy with you if you do that. And well, don't bow down to the pressure. And don't bow down to peer pressure. And that's not just in teenagers, but also us, peer pressure. And dare to challenge the system. If you see something and you think it's not right, especially in a society, you see something, you think you can do it better, you think it's not right, you take the bull by its horns and you do it. And that's it, just do it. And challenge, you're willing to go out there, put yourself there and challenge the system, of course, diplomatically. And I think that's also very important. If every single president or top person in the society just follows and plots on what the previous president does, then we're not going to be able to move forward. So you've got something to bring to the table. And for that to happen, you can't buckle under pressure, and you would dare to challenge the system. So what we have discussed then were gender disparities in medicine. From the studies, it seems that it's there indeed is gender disparities in the upper echelon of medicines. And we also know that there's subtle biases not in the evaluations, and that's something going to be difficult to try to overcome. And what we're doing now, I think it's the correct way, and we're drawing attention to this We're making people aware of this gender disparities in medicine so that we could find a way around it. And I discussed about traits of a successful person or leader, not just from that systematic review, from Google. And you note that they never mentioned about successful traits in a female or male. They make no mention to it because the successful traits are the same, whether it's a male or a female. And well, I'm going to end with this, and the very, very famous and also successful campaign says, just do it. And in also the words of a very venerable guru in a galaxy far, far away, long, long ago, he says, do or do not. There is no try. This is Master Yoda, Jedi Master. And ladies and gentlemen, whether you're female or not, the world is your oyster. The only thing that is stopping you from getting into that top position in medicine is you yourself. Know what you want, know who you are, be happy, and just do it. Thank you very much and good luck.
Thank you so much for your excellent and marvelous talk, Dr. Vivian Lim. And I have a question to you. Do you think that the female medical societies should be formed exclusively by women, or could something contribute that they also have male members? What do you think about this?
Oh, I think certainly we definitely should get male members in. Variety is the spice of life. And if you only have your view and not somebody else's views, it's very narrow. You have blinkers on, you know. So I'm all for having males inside at the same time.
Okay, thank you. Yeah, I think also the same. Yeah, I think that we have to work all together. Yeah, it doesn't matter the gender. Yeah, and then we can learn a lot of things from both sex. Yeah. So let's keep on going, and I'm going to do my talking. I think that Saskia is going to introduce myself. Saskia, are you there?
Yeah, good evening, everyone. Let me introduce the convener of our today's symposium, that is Dr. Elena Ruiz-Ucar. She is currently a associate surgeon in the Department of General and Digestive Surgery and Endocrine, Bariatric and Metabolic Surgery Unit at the University Hospital of Fuenlabrada, Madrid, Juan Carlos King University. She completed her residency in general surgery from 2006 to 2011 at the Gregorio Marañón University Hospital, Madrid. She has been fellow of several scientific societies that include member of GERM, that is Spanish Multimodal Rehabilitation Group, member of SICO, that is Spanish Society of Obesity Surgery from September, member of IFSO, that is International Federation of Surgery of Obesity and Metabolic Disorders, member of SINPE, that is Spanish Society of Parenteral and Enteral Nutrition, member of ESPEN, that is European Society Parenteral and Enteral, member of the ES, European Association Endoscopic Surgery, member of the Spanish Association of Surgeons since 2006, that is Obesity and Metabolic Surgery section of the Spanish Association of Surgeons, section of Minimally Invasive Surgery and Technological Innovation of the Spanish Association of Surgeons, and member of the Official College of Physicians of Madrid since 2006. So let's have Dr. Elena for the next talk. Welcome, Dr. Elena.
Okay, thank you. I'm going to share my screen if it's possible. I don't know if, oh, so sorry. I think that I have to, it's possible to see my screen? Hello?
No, it's not.
No, we can't see it, Elena.
Oh, I don't know where, I don't know what I have to do. I have done something wrong, I think.
Maybe till you figure it out, Zarina had a comment to make. Zarina, can you unmute yourself?
Yeah.
Alina, you are co-host, right?
So that was I thought that was a really excellent talk, and I love the motivational element. I also love Singapore because I did my microvascular training there. I would say that we had a huge debate when we set up the UK Society of Women in Maxillofacial Surgery. It was at a time where we were very much the minority in the specialty, and we still remain not the majority, and we're certainly not equal in number, but we certainly are rising in number. And what we set up our society for was not so much as, it was about motivating, it was about providing evidence of role models, but what was also really, really important was the psychologically safe space. What we also realized in surgery, certainly, that there is a desire to fit into that image of being in the group, in the greater echelons of our once face-to-face conferences that are no more face-to-face. But what was also a problem was that there was nowhere really where you could have a bad day and have a rant about, you know, your kids going crazy or whatever you were doing. So and also about bullying. You know, it was really, really important to have a space which was confidential, protected, and psychologically safe for women to feel like they had a place to raise concern. So we don't have men on our forum. We made a decision not to have men on our forum, but we encourage people who champion us to lecture at our conferences every year. So there's always been a balance between the presence of men in our Women's Society for Maxillofacial Surgery in Britain, and it hasn't been a bad thing. It's been a very positive thing in terms of the representation of women in leadership roles in the UK. So we started out with an absolute minority of women in our National Society Association. This year, 80% of elections, which have been men and women voting, have voted for women. So that is a good sign that women are making big headway in leadership because of the support of other women, and also the recognition that they have a louder voice and confidence. So I would say that that's just a different perspective. It doesn't mean it's the only way, but it's what's worked for us. So thank you. I'm going to mute myself again.
Thank you so much, Zarina, for your comment. Dr. Vivian, do you have anything to say to that?
No, I think it was an excellent point. As you rightly pointed out, there are different ways to skin this cat, and really depends on the aims as well. And I totally agree. If there's an aim is a safe space, then yes, we would really like just to have the women there. But let's say if it's something else, it's without discussion about women, gender roles, I would like to have some men there as well. I mean, who's to say you can't have both? And then you can have a safe space and a particular session where it's only for women only. And then you can have sessions in which you can have both men and women, and you can have your cake and eat it.
Right, thank you so much. And let me just see if there's any other question. I think there are more compliments than questions for you, Dr. Vivian and Dr. Sonia, both of you. I think, Sonia, there was a question for you from Dana. She said she wanted to know about how to, she says that she's coming from a country which is not well established in research, and she's now over 30 with little research experience. And what is your advice to keep motivation, not to compare yourself with others or think about being a bit old to start proper research career?
In my opinion, obviously it is most important to start at a young age, but at the end, you have to follow your passion. When you want to do something and when you like it, you can also start over 13. You have to work a lot doing science as a female surgeon. When we talk about surgery and science, is hard because you have to learn to operate and you have to do science. So obviously in the younger age it's easier, but when you just started a surgical career and you want to add on a scientific work, obviously you can do it also over 30. We have to work until maybe 70 years. So you have 40 years to work on it. So do what you want to do when you are curious, when you want to write, when you want to study, started also over 30 years, obviously.
I was just wondering, is Alina having a technical problem? If so, would you want to go on to the debate first and then go back to Alina?
Yes, that's what I was going to suggest as well. I think let's move on to the debate because I know Dr. Lim, it's very late for you. Alina, let's move ahead with the debate. You're on mute, so let me just, will you please invite Dr. Higa and Dr. Pratibha? Alina?
Yeah.
Yes.
Sorry, it's so many.
I'll just make him a co-host as well.
Okay, so sorry. Yes, let's go to the debate. Dr. Higa, he's a board certificate in general surgery and has performed open bariatric surgical procedures since the early 1990. He's specialized in difficult and challenging cases. He serves as associate editor for many peer-reviewed journals and has authored many original articles and book chapters regarding bariatric surgery and complication management. And he's a clinical professor of surgery in the University of California, San Francisco, Fresno Medical Education Program. And he's also past president for the American Society of Metabolic and Bariatric Surgery, and continues to chair many international conferences devoted to bariatric surgery. So he's going to make the talk and the debate with the doctor. Also, so sorry, but I have a lot of problems with my computer. Oh, so sorry today. You know, sometimes
I can introduce myself.
Okay, and yeah, no, okay, I have the introduction for the Dr. Pratibha Mulapalli. She's an American board certified surgeon specializing in laparoscopic and bariatric surgery. And upon receiving her medical degree from Jefferson Medical College, she completed her residency in general surgery and her research fellowship at the University of Medicine and Dentistry of New Jersey. She was fellowship trained in both advanced laparoscopy and laparoscopic bariatric surgery at Montefiore Medical Center. And she's part of the Brooklyn Hospital Center, where she makes minimally invasive surgery with inpatient volume growth and multidisciplinary obesity management with creation of a center of excellence. So please, we can start our debate. Dr. Higa and Dr. Mulapalli, and please start your debate when you want, please. Okay, I think that, for example, we can start with Dr. Pratt. She is going to talk about the point of view in this interesting topic for 10 minutes, and then Dr. Higa. And as we said before, then we can make some question about the debate and the discussion. Please, Dr. Pratt, if you want to introduce, to start. And Dr. Higa also. the presentation, please? Okay. Dr. Pratt?
She's unmute. Tell her to unmute.
Oh, there we go. Can
Yeah.
everybody hear me now?
Yeah.
Okay. I think I'm having some trouble screen sharing.
It's me. Oh my God.
So
We can see your slides though, Dr.
you
Pratibha.
can see the slides?
Yes, we can.
Okay,
You just have to
perfect.
make them full screen.
Okay. I'm trying to make them full screen here, but oh, there we go.
Yeah, that's perfect.
So, thank you. All right. Thank you guys so much for inviting me. So as we look at this first slide, as you look at this, people in the audience are going to perceive or see several different things. Some of you may see the phrase morality is now here. Some of you may see morality is nowhere. So the important thing about this topic is it's not really about morality. It's actually about the fact that it's about our perception and our perceptions towards parity. That is, women getting equal representation at all levels of the medical ladder. So why do we need men, right? That's because when we talk about parity, men represent, depending on the country, between 70 and 90% of doctors that exist. So if we can't get the majority involved, I think Dr. Lim put it best, the youngest person in this room will certainly be done with their career by 21, 36 and may not even be here to recognize parity. So we need men to get involved so we are not having this same debate for the next 120 years. 2015 in the United States was a monumental year. It was the first year that medical students entering medical school were 1/2 or 50% women. The pandemic has a very unique distinction for women. It was the first year in the United States that 1/2 of the graduating doctors were women. And that's a huge achievement. But when you look across the medical spectrum, you see, and it depends based on specialty, and Dr. Lim's data was absolutely right? Surgery is one of the worst. OB and primary care do slightly better, but especially in surgery and really overall, women still represent the lowest rungs on the medical ladder, meaning 3/4 of women are at the lowest academic distinctions, instructor or assistant professor, as we can see by this graph. When we talk about climbing the academic ladder, the herd gets thinned out. And at full professor, there's only 10% that are women and 90% that are men. And most of us know that it's the full professors that are deciding who's going to be trained, that are hiring, that are advancing people's careers, and are determining how much everyone gets paid. So that's why we need men involved, because men actually are making 90% of the decisions. The second reason we need to get men involved is bias, social bias, implicit bias, cultural bias. As we said, men are, right, we all know this, 50% of society, 70% of medical culture, but 90% of medical decision makers. So what are our biases? What is everyone's bias? And I'm going to try to play this video here. So this is a social scientific experiment, right? Here's a woman, she's at a busy train station. It's an actor, she's pretending that something's happened and she's fallen. How long is it going to take for all the strangers walking by her to stop and help her? She's well-dressed, she doesn't appear to be a threat. But how long will it take for people to say, this is a woman, we should help them? Now you can see the clock on the right-hand corner there. We're at about 4 minutes. Many people have walked by, but nobody's helped. Now here we are at almost 5 minutes. right? Someone's looking intentfully, but not helping. And finally, at 5 minutes, 55 seconds, almost 5 minutes later, someone comes over and helps. Also notice once the first person comes to help, the second person is not far behind. It takes seconds for the second person to come in and help. And that's also social science. Now let's do the same experiment with a man, right? Same train station, man falls down, same time of day, same location. How long will it take for him to get help? There we have it, 6 seconds. So it took 300 seconds for a woman to get help, but only 6 seconds for a man. And the same principle applies. Once the first person helps, another joins in and another joins in, right? So this is social bias or implicit bias. It's the bias that exists. But if we don't dispel some of these biases, right? Or said a different way, if our male colleagues don't recognize these biases and help us dispel them, it will take till 2036 for us to achieve equal numbers, but maybe beyond 2136 to actually get to true parity. The third reason that we need men to help, innovation. So 2 things about me. 1, I'm desperately waiting for autonomous cars because I hate driving. But 2, I love Star Trek. And what I love about Star Trek is that little beeping machine they have, right? Beep, beep, beep. You've got a fracture. Beep, beep, beep. 10 seconds later, the fracture's healed. Beep, beep, beep. I can make a new kidney, right? It's inside of you and no scars. So that's what I'm waiting for. How long will that take if we don't use all of the brilliance that we have? If we have 50% of our population not using their intelligence, not using their creativity, not using their innovative skills. As Dr. Lim, to quote her again, said, right, Singapore, where would Singapore be if half the population wasn't working towards those goals of innovation and medical miracles? So let's take this out of the theoretic realm for a minute. This is the first picture taken of DNA, right? This was the picture, 1, 2 strands that helped Watson and Crick come up with the fact that DNA was a double helix. It's just coincidental that there happened to be 2 X's there, right? For women. This was the person who took that picture. Where would Watson and Crick have been if she didn't take that picture? Would they have been able to figure out that DNA was a double helix? Maybe eventually, but it would have taken a lot longer. So that's the real life example of innovation. And it's only one of many of why we need women involved, but why we need men's help to get us there. My final appeal is the golden rule. Paraphrased, do the right thing. So this is something that each of us teaches our children, male or female. This is something we teach every medical student, every resident, every junior colleague. It's what we tell ourselves to do. So we have to appeal to the men in the room, the golden rule, do the right thing for all the women who are around you, who are your children, who are going to be your forebearers. Do the right thing for society so that we can all get there together. So that's, I hope, my arguments, and I hope that you are convinced that men should help women. I want to talk for a minute on why men, especially in that passive bystander role, may not. Because if we're really going to get there, we have to have strategies to figure out, what is other people's reticence. So think back to that video that I showed you earlier, right? These are the reasons why bystanders or other people, perhaps men in your departments, may not be getting involved. Diffusion. There's 40 people walking by. Somebody else will do it. Ambiguity. Is that person really fallen or are they just asleep? I don't know. Personal cost. I'm late for a meeting. I have to go. I can't do it. And of course, apprehension, right? Is there a risk? Do they have a gun? Do they have a knife in that handbag that was next to that person? Is there a risk to me? So I think it's important to think of these obstacles and to have strategies around how you're going to get around them. And I always say, don't wait for the crowd. Don't expect the crowd to help. Single somebody in the crowd out. Usually a crowd walks by you, but if you look at somebody straight in the eye, and this has all been shown in social science, if you look at them in the eye, if you call them by name, it's very hard for someone to ignore your request. If you back that up with having a specific request, people will often help. And with that, I'm happy to give the floor to Dr. Higa or answer any questions.
Yeah, I think that let's go with Dr. Higa, yeah, and his talk and why the question for him, yeah, that it's just women. The topic for him is women don't ask, so they don't get a seat. So we are going to listen his point of view about this question, about this topic. Please, Dr. Higa, start when you want, yeah, and then afterwards we make some questions.
Okay, well, I want to make this short because I think it's really about the debate. Really enjoying being part of this symposium. Thank you for inviting me. I feel like I've learned quite a bit. All the lectures have been fantastic, and it's not going to be much of a debate because it's hard to debate something that you don't believe in. I know it was kind of set up that way, but just as a disclosure, I don't think that it's a problem with women not asking. It's a problem with men not asking them. And it's, it was said very well today about the gender bias. And you have to understand the definition of bias is that whoever is biased, they don't know that they're biased. It has to be pointed out to them in some way, shape, or form through education. For example, the American College of Surgeons, the governors, the leaders of our surgical specialties, in a survey point out, absolutely there's a problem, absolutely there's bias, absolutely we need to change things, and yet 83% of the governors are men. And so this sort of propagates itself in a way. We all agree, but like I told one of the few advices I give to my daughters is this: doesn't matter what the boy says, what he does, that will tell the story. So I totally agree that we can all say in theory that there's a problem, but until we start acting on that, until we start really delving into the problem, that's where the issue is. Now, I'll have to say that probably a good example of bias in a way, because unlike all of the speakers who've been here, and I've been impressed by the work, the ambition, the drive, all the things in personal life and professional life, and I'm none of those things, and yet I've risen to certain levels of leadership, both of the ASMBS and of IFSO, and not because I sought it out or asked to be there, but it was asked of me. So virtually no effort on my part. And I was asked to do these things. And I'm probably the least ambitious person in the world. And as what Dr. Lim said, that if you were to look at my life, I would be that useless piece of furniture at home. So I work, and then I come home, and I'm not really contributing a lot. Well, thank goodness it worked out okay, because we just celebrated our 35th wedding anniversary. We have 4 kids, 3 grandkids, and time has allowed me to understand how closed and how narrow-minded my earlier years were, but it's only through education and probably because of the women in my house that constantly bombarded me with the facts that I came to realize these things. But as a leader, it is our responsibility to seek out the best and not have them approach you, but to actually endeavor to develop that diversity and look into all of the aspects that makes an organization great. And clearly, I love those social experiments where you analyze why people do things and why they don't, why they come to assist. I could do an experiment as well if if I had trouble lifting my luggage, how many people come to help me? But if I were a young, attractive woman, how many people come to help that person, right? So it's more complex than simply it's a man or a woman, dressed or not dressed, and that sort of thing. It's a great example. And I love the Star Trek because I love Star Trek too, because of that. But it's clear that when you really look at groups, collaboration, the women groups collaborate much better than men. They work together much better. They are more apt to ask other advice. I mean, this is just traits that we see. And so when I'm designing a committee, or if I'm looking toward having a group that's looking to spearhead innovation, then we have to be at least 50% or more women. In fact, I like it more because I know that there's less ego and more just get the work done. And so I'm glad that there's a forum to help everybody endeavor to work in this marketplace. And I am proud that currently more than 50% of our medical school graduates are women, but only a quarter of them go into surgical specialties. They're gravitating to other specialties, and for a variety of reasons. And with that, I think that's all I have to say. I have a question though about the bias, and we talk about the safe space and that sort of thing. For us, we know, I don't know how it is, but the operating room has always been our safe space where we can be politically incorrect, we can tell jokes, we work together as a team, and that's part of team building. But with all of these concentration on racial bias and that sort of thing, all of a sudden everything, it's like we're walking on eggshells all the time. And do you think that sometimes all of this biasing is really interfering with our ability to collaborate and work? Or is it really just that we're so insensitive, or I'm so insensitive that I don't understand that I'm really making people feel uncomfortable?
Would anyone like to take that question?
Yeah, I mean, I'd be happy to start. I think, I think that's a great question, Dr. Higa. I think every surgeon asks the same question. I've heard it many times. And I think especially male surgeon, I have a good friend in his mid-60s, off-color jokes all the time, 3 daughters, no sons, talks endlessly about his daughter's success, in their jobs. So I know that there's no deep-seated bias against it, but I think it's about, I truly do think this. I think the majority of people are not offended, but there is a minority that is offended. And I think we do have to somewhat, to include everybody, work towards, bringing everything, I think, into the middle. One of the things that I try to do in my operating room, because I agree with you, I love the banter. You can only talk about, what suture you're using so many times, and then it gets somewhat boring, and you want to engage everybody. So one of the things that I try to do, I love Star Trek, and I've never tried this with Star Trek, but we have these reality TV shows. One of my favorites is, please don't think any less of me, everybody on this call, The Real Housewives. So for years, every season, I make everybody in the room watch the same show, usually The Real Housewives. And that way, all of our conversations are usually pretty benign about the same topic. And it's usually a very safe topic. And that's one of the ways I think I've tried to build, I think, safe teams in that space. But I think what you're saying is very true. And I think there are many, many people who feel that way. And that's a technique that I try to tell people to use. Pick a TV show that's safe, that everybody can talk about.
Yeah, that's a pretty good. I think for me, just being approachable. I mean, there are surgeons that are approachable, there's surgeons not approachable, and it depends who you are. Every time somebody new comes in the OR, I usually begin by saying, well, we talked about a lot of things just to amuse ourselves. If anyone's offended, just speak up, we'll stop, done. But then again, nobody wants to speak up, say I'm offended, but it's out there, what's out there. And I'm hoping that people don't really take offensive things we say, but I know that there will be. It's the nature of the game. But anyways, I wonder if there's things that the topic about being a leader is one thing. I mean, everyone on this call is exceptional. Everyone is at the top 1% of, but there's most physicians, most surgeons don't want to be leaders. They don't want to get into the C-suite. They don't want to do any of that stuff, and that's okay. But it is a difficult thing, especially in the United States, when you begin your career, you start your surgical career, your first job at the age of 30, usually after residency, and that is a really difficult time to devote to building a career, writing papers, starting a family, all those sort of things, right? I mean, I think Dr. Chiappetta, for example, I'm really interested to know, because you are married to a surgeon. I was in a group where several of the individuals were married to each other, but the way they handled it was that the women surgeons wandered off into breast, vein surgery, some of the more, lifestyle changes, which I felt was a big tragedy. I thought all of that training, all of that endeavor, excellent surgeons, brilliant minds, and they're not using it with the training, and they're, because of lifestyle, going into an area that's still needed, but not necessarily taking advantage fully of all of their skills like you did. And that's one of the problems is for myself as an educator, I see, and as a mentor for many junior of our faculty, we spend a lot of time training. At the end of that, for whatever reason, for other reasons, a lot of our surgeons don't take advantage of all that. And I'm trying to understand how we can do that better. So in my new group, we really have to, we allow a lot of leeway into what stage of life you're at. And I'm hoping that they'll give me some slack too when I slow down. So in a way, we should probably work hardest at the end and spend more time with our families in the beginning, but I don't think that's going to work out very well.
Can I make a comment to that? I thought sometimes it's not, those surgeons that decide to go elsewhere and take a lifestyle change. I say in my talk that you must be realistic. It's all about passion. And you make the decision then what the sacrifices you want to make and whether you want to continue on this path. And sometimes decisions change, mindsets change. What you have decided when you're 25, when you're 30, when you're 33, when you're faced with time left to be pregnant, and you've got that baby, and then suddenly you decide, and I know many friends like that who are surgeons, and they decide that that's more important. And what they taught 3 years ago suddenly changes. So it's no one's fault. It's just they were honest with themselves. They sat down and they decided, I want to spend 20% on my child, and I only now have 2% for this particular career, I'm not going to do this. I've made that decision. And life is not fair. You know, but she did the best she could, and that was the decision she made. And you know, if she's happy, I think that's the decision she has, and it's just no one's fault.
Difference between equality and fairness. Understood.
Okay, I think it's a great discussion, a great debate, but it's a little bit late. Also, I don't know what you think, but I don't know if you think that it's better if we put my presentation now, or I don't know if very late for some people in the webinar and the symposium. So I don't know if you want to finish right now, or at least, for example, put because I think that we have talking about the main things, and I have, for example, in the presentation, I have the last slide is you know a summarize about this what we have talked about. And if, for example, my presentation is too long, but for example, we can put the last slide just to summarize what we have talked about, and you know, I don't know what you think, Aparna, for example, or because it's
Alina, I think you can take a few slides and whatever you would like to go ahead with, please do. I'll just share my screen and share your presentation.
Okay.
Is it visible?
Yeah, that is.
You will need to tell me to change the slides.
Okay, perfect. So, okay, I go quite quickly. My talk is about machismo culture and its repercussion for female surgeons. So please, Aparna, the next one. That's my disclosures. I'm in favor of kindness and respect against bias and discrimination based on sex, race, or religion is outside of any democratic state. Please, the next one. So we're talking about 4 points. What is machismo? Male predominant surgery field, surgeon stereotype, and woman in surgery effect needs on further action. So please, the next one. So what is machismo? History and etymology for machismo is Spanish from macho, and macho is having or showing qualities such as very, you know, a strength and aggression that agree with traditional ideas about what men are like. Manly or masculine is a very, you know, exaggerated way. So machismo is an attitude, a quality or way of behaving that agrees with traditional ideas about men being very strong and aggressive. Please, the next one. So a male predominant surgery field, we can see that, for example, in 2017, 40% in US general surgery residents were females, and 20% of general surgeons were women. So although there is an increase in each of the surgical specialties, there is still very little, as you can see in that picture, where, of course, between 13 and 17 surgical specialties, women increase the number, the percentage, but it's also very little percentage. So please, next one, Arne. So the father is nice, you know, when we use the father, we can say we listen about the father of different aspects of surgery. It's commonly used, but never the mother. And so why? And if you, for example, talk about the 24 pioneer of surgery, no one is a woman, although their notable contribution to surgery, but pioneer, no one is a woman. So the next one, please. So what about stereotype in surgeon in the machismo culture? Okay, that the stereotype is because we suppose, or society suppose, that a surgeon must be aggressive and arrogant and difficult to work with, and with a big ego, and angry and impatient, or yelling and throwing instruments, you know, ordering people to go out from the theater. Please, the next one. So, but we have to go to data, to objective. And if we take a look to the literature, we have a lot of papers, many papers like this, for example, published in JAMA in 2020. And the conclusion is that the perception of pro-male bias and gender stereotypes may influence career engagement and skill performance, respectively, among surgical trainees. And the next one, slide, please. And for example, in 2015, Heather Lodge, medical doctor, they tweeted the suggestion for a hashtag, I look like a surgeon. And this hashtag is spread very quickly all around the world. And from many societies, women's societies, and it had a very a strong impact in the world. Please, the next one. For example, another paper about women in surgery and the effects and needs and further action. So, however, referring to the current literature, it still reflects that there are many differences and inequalities between the sexes. So not so much in the global medical community as in the surgical one. For example, in this paper, where we can read that women surgeons publish research at a rate proportional to the number of females involved in this specialty. So we have a lot of disparities in leadership roles are unlikely explained by differences in publications. The next one, please, Aparna. And also we can see here two more papers about the gender in authorship and editorship in medical education journals. And the conclusion is that positive progress towards gender parity has been made in medical education scholarship, but however, future research and efforts are needed to ensure the continued participation. And also, for example, the disparity in gender in, for example, the Surgery Infection Society, where the conclusion in this paper is that female surgeons are underrepresented in this society. So whereas the number of female surgeons and residents has increased, these trends haven't occurred with council membership and leadership in the society, in surgery societies. Please, the next one, Aparna. And also we have this paper is a systematic review and about the learning and teaching of surgery. And in this review, the conclusion is that bias against women in surgery is still a sex, and there is a lack of studies that investigate the role of women in the teaching of surgery. So the next one, please, Aparna. And we can also see in these two papers that the role of gender in the decision to pursue a surgical career, and also the perception in gender disparity in surgery and surgical leadership. In these papers, we can see that, for example, in the conclusion of the second one, that both female and male surgeons report substantial gender-based barriers in surgery for women. And despite improvements, limited support for surgeons with families and disparities in promotion persists. So please, the next one, Aparna. And quite quickly, but this is another interesting paper in clinical in orthopedics and related research that we can see that, for example, in the graphic, that all about, we can see a lot of societies, and also always men represent much more speakers than women speakers in this Congress. So there's a very important thing that we have to think about. Please, Aparna, the next one. And also here we can see the same, that the percentage of men are much more higher than women. As women members, we represent a very little percentage if we compare that with men. The next one. So, for example, if we talk and if we ask for in in hospital and in the American College of Surgeons, if gender equality is a problem in the surgical profession, for example, we can see that 40% is agree and 17% is strongly agree. But we can also see that, for example, is disagree at 14%. So there are many, there are also in our societies, in our profession, people who think that there is not a problem, and that it's not a problem, the difference between genders, but it is. For example, if we ask about what is the biggest impediment to gender equality in the surgical profession, we can see different aspects, and the main, that 35%, for example, the fellow surgeons is the main problem. Or if we ask about if you have a colleague that being treated negatively or with harsh said by colleagues, we can see that we have okay, mainly the 50% say that no, but also 34% yes. So that's a great problem to us. Please, the next one, please. And if we see this about, the earnings, this very nice paper, because they tried to investigate if we earn different, money because of our gender. And the conclusion is that even within a fee-for-service system, male and female surgeons do not have equal earnings for equal hours spent working. So that's suggesting that the opportunity to perform the most lucrative surgical procedures is greater for men than women. So that's also very, very significant. Please, the next one. And just, for example, if we say the professional differences, we can see that, for example, in physicians and surgeons, we have, if we see the 15 major occupations, for example, surgeons is one of that occupation that we earn different money from, from the genders. So this is also very important different and a great problem. The next one, please, partner.
Sorry, it's yeah.
No, of course not. So, and just for the end of the presentation, if we look, for example, other hashtags like he for she, and it's very important, the social media where we can find, that kind of societies like the Association of Women Surgeons, that is the only way the stereotypes can evolve, through repeating the exposure of people who contradict these stereotypes, as, for example, Association of Women Surgeons, or, for example, famous actresses, or that are fighting about, against this conception and these stereotypes. The next one, please, Vernon. So, for example, and I want to share this with you. There's a partner I mean that it's so in 2019 in Madrid. And it's very important, the role and mentoring model of women. For example, she is a mentoring model for me. And I think it's very important to look for mentoring and for mentors with professionalism, excellence, innovation, and creative thinking and introspection. I think it's very important to look for this kind of mentoring. The next one. And just the end in the statement, it's very nice because in 19, the American College of Surgeon Women, the committee statement, that build a culture of respect and collaboration is necessary. Also, the healthcare professionals should have zero tolerance for discrimination, harassment, or bullying. Administrators should develop and implement transparent policies to address it, and staff, physicians, and trainees must have access to non-punitive reporting, counseling, and rehabilitation programs. And surgical training should include a curriculum to address implicit bias. The next one, please. So in conclusions and take-home messages for me, I had to say that historically macho culture in surgery must be abandoned, accept that there is an implicit bias in surgery wall. We must finish with surgery stereotypes, and exposing them is the way. Social media are a great channel to do it, I think, and zero tolerance to gender bias and discrimination. And women in surgery have a role model in mentoring. So that is my presentation, and that's what I want to tell you.
Thank you so much, Alina, for a wonderful presentation, wonderful talk, and bringing out a lot of topics that need to be discussed. And I must say that this has been a very wonderful session with participation from all the speakers. I'm so grateful for all of you to be here, to devote your time for this program, and also to all the participants who had their comments. So just a few things. I think it's there. So one of my friends, a surgeon friend, asked me that, do you really think there is a need for a separate women in surgery association, because men don't really see the problem because they're kind of oblivious to it, and probably because we don't really talk about it enough. So it's just about women not asking enough, right? So so my answer to that was that if there was no problem, then there would be equal number of women in surgery. I mean, it would be 50-50, and there would be no problem with pay parity and things like that. So definitely there is an issue, and it needs to be addressed. And I think the first step to start addressing this is by having conversations like this. Of course, we can't solve the problem in one day, but we can't wait till 2136 for the problem to get sorted. So we need to have these conversations. Is very important. And Dr. Mahavar knows that I was very apprehensive to actually initiate TUGS Women in the first place, because I just thought that maybe it will stereotype me as only a woman surgeon, and most female surgeons don't like to be called as female surgeons, right? We are all surgeons at the end of the day. So, so yes, I mean, we're all here, and this is our second program, and I'm really glad that we're doing this. And I think every time I dedicate this program to Sakshi, because she is a young aspiring medical student who really wants to get into surgery. And I think it's for all of you, all the students who are looking up to people like us who've, at least taken that first step because we saw somebody else taking that first step. So, so if I can convert even one student, female student, to surgery, I think it's really worthwhile. Sonia, you have to say something. Please go ahead.
Yeah, thank you. I have to say some critical point, because at the end, I have to say we have to accept that there is a bias. We are women, and women are different from men, and that is important. We don't have to look for equality. Like Kevin Higa said, there are a lot of women after getting the first child decide to be more mom than a surgeon. And this is an important decision, but this decision has to be your own decision. In my opinion, to get a female surgeon in a leading position, for getting it, you have to have a good background. So we have to work for, I don't know, getting helped for private things. There you have to look for. But at the end, if you decide to get a female surgeon, you can do it. This is not a problem, but you have to accept that it's really a hard job. And as a woman, you have to work harder, and you will always be different from men, but this is okay. I have to say, you also have to accept it, and you have to be happy with it. So I don't want to use the excuse, for me it's too more difficult because I'm a female surgeon. it's more difficult for women, yes, but it's not a problem. You have to fight for it. So, and you can achieve it. We have a lot of models who show us that it's possible. So I think we have to focus more on this, to have that yourself, you have to decide what you want in your life.
Right. Thank you, Sonia. Dr. Ritu, you have been through the whole program. Please go ahead.
Yeah, thank you so much for taking this initiative. You've always had some very good speakers and very good experiences to share. And I really feel so amazed that it's not just about one country, India or Asia or Italy, or for that matter, any part of the world. We get to see and we get to hear some similar stories across the board. One point which I wanted to highlight when you said that we have actually broken the barriers, because when I joined in 1997, we had a couple of female lecturers. But now if you look at the Department of Surgery anywhere across any medical college, you see that more than 50% of the students are comprised of ladies. And not only that, as we see in this forum, in any department for that matter, more and more number of females have already made a mark and have broken that stereotype and been involved in the surgical profession. So we are already there. It's just that, as you correctly said, that we just need to put forward the point that it is possible, it's been done, and then portray it to the others. So where are we actually fighting? My point is that we acknowledge the bias, we actually kind of fight it out every single day of our practice. And not only it's about where we had been successful is in the work which we have done, and we are all happy about it. Where we are still lacking is being acknowledged by others who have recognized that we have done equal amount of work. Now, these others are both the patients, the general layman people, and our colleagues and the so-called societies and the departmental heads and the administrative people. So joining together forces is not just about trying to prove a point that we can do an equal quality of work, equal quality of research, equal quality of publication that we have done and been there. Now it's time for us to get together to prove it to these other groups that yes, we are as much equal, or if not equal word, because you are different than me. I may be different from XY other female for that matter. So gender is not just one thing that we have to portray. We have to portray the quality. Why, as a women, we can be better, we can be more, as everybody has been talking about attributes. Dr. Kevin Higa just said that women are made different. Yes, we are made different. So I won't take it longer. Aparna, thank you so much for this opportunity, for bringing all the good people together, and hope to take it forward more and having such beautiful minds and theories behind us. It's an ongoing topic and debate, so we can keep on talking about it all the time. Thank you once again.
Thank you so much, Dr. Ritu. Thank you, Sonia, Dr. Lim, Dr. Higa, Dr. Pratibha, and of course, Elena, for being the convener for this lovely program. And Dr. Mahavar, thank you so much for having TUGS Women. I think that is the starting point. So it's a heartfelt thank you to you. Thank you so much.
Thank you to you, Aparna, for leading it. We've done nothing really, and the fact that you've put together here a program with us, I can say colleagues from more than 10 countries around the world, that is a start. And we start having difficult conversation, we'll get there in the end. So this is the beginning. I'm sure 20 years down the road we'll feel differently about these things, and then we'll look back at this day and we'll say that's how we began. Well, thank you.
Thank you so much. Thank you, everyone. And we look forward to the next program, hopefully in another couple of months. Thank you so much. Bye.
Thank you.
Thank you.
Thank
Good
you.
night.
Bye.
Have a good day. Good night, everybody. Thank you.
Thank you, everyone. Good night.
Bye.
Bye.